Welcome everyone to today's program. I'm Heather Punke with Becker's Healthcare. The program will begin with a presentation and we will have a question and answer session following completion of the presentation. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenters will attempt to answer as many questions as they can during that time. You will receive an email within about a week following the webinar that will include instructions for how you can download a copy of the presentation. You will also receive a follow-up email shortly after completion of the program. You can submit your feedback or any additional questions at that time, but that email will not include the presentation. It is now my pleasure to introduce today's presenters. Dr. Alexander Strawn has more than 25 years of clinical experience as a practicing internist and hospitalist. He joined MCare in 2015. Dr. Strawn has served as CEO and Managing Director of a management consulting firm with a focus on strategic hospitalist program development, restructuring, and implementation for health systems, hospitals, payers, and provider organizations, and medical foundations. In 2012, he served as one of the founding medical advisors of Remedy Partners. From 2002 to 2007, he successfully led the development of a large hospitalist division for a national staffing company, overseeing program operations for 5 hospital medicine programs. He has presented for the Society of Hospital Medicine on the topic, When Does Your Practice Need Therapy?, providing information designed to help physicians improve documentation and performance. Dr. Strawn received his medical degree from Columbia University in New York City and holds a master's degree in business administration from the University of California, Irvine. Next, we have Dr. Asim Uzman, who is a hospital medicine physician in Dallas and has been with MCare since 2001. Dr. Uzman won the 2014 Summit Award for Hospital Medicine and is Divisional Executive Vice President for MCare. Dr. Uzman is board certified in internal medicine and hospice palliative medicine. He is an active member of the American College of Physicians and a senior fellow of the Society of Hospital Medicine. He also serves on the Texas Local Advisory Board for the Doctors Company. Throughout his career, he has served in various roles and functions, including Credentials Committee, Utilization Review Committee, Chief of the Department of Medicine, and Chief of Staff. It is now my pleasure to turn the floor over to Dr. Uzman to begin today's presentation.
Good afternoon, folks, and for people on the West Coast, good morning, and thanks for having us today. So today we'll be discussing bundle payments for care improvement, and I'm sure you guys realize this is not a galaxy far, far away. It's here, and we should have our lightsabers ready. So hopefully we'll get prepared for this more by the end of this session. The bundle payment program is an alternate payment model for CMS. Today, we will discuss what is BPCI, what's different in this program, and what stays the same. The why do we want to look at this alternate payment model, and why is it being pushed by Medicare? The when, what are the timelines? The who are the stakeholders? Stakeholders who would want to change and the ones who will not be completely aligned with this change. And finally, the how will organizations approach this change? Now, BPCI is comprised of 4 broadly defined models of care and link payments for multiple services received by beneficiaries during an episode of care. Next slide. So we all know there's a shift going on in payment methodology, and we can broadly put these in 4 categories. The first one is fee-for-service. We all have been living this for the last 50+ years, both in the hospital and in the outpatient world. The second category links quality to fee-for-service. We have witnessed this in value-based purchasing, physician value-based payment modifiers, hospital-acquired conditions. These are some of the examples. The third category, which we'll be looking at today, is built on fee-for-service architecture. Some of the payments are linked to population management episodes triggered by delivery of service with shared savings. Your BPCI model, ACO, medical home, Medicare, and Medicaid financial alignments are some of these models. We are suddenly finding that the hospitals are getting more and more responsible for the cost and efficiency attached with care provided outside the hospital. And the last category is population-based payments, your eligible Pioneer ACOs. These are not linked to volume. These are designed for organizations and providers that are already experienced in coordinating care for patients across care settings. This allows groups to move more rapidly from a shared saving payment model to a population-based payment model. This is designed to work in coordination with private payers by aligning incentives which will improve quality health outcomes for the beneficiaries. Next slide. So under these models, organizations enter into payment arrangement. We're talking about BPCI. Organizations enter into payment arrangements that include financial and performance accountability for episodes of care. These models may lead to higher quality and more coordinated care at a lower cost to Medicare. There are 4 models proposed. The first 3 are retrospective. The 4th model is prospective. The 4th model is prospective acute care hospital stay only. Now, as of April 2016, in the first model, which is a retrospective acute care hospital stay only, there has been only 1 participant. Models 2 and 3 are the more popular ones. In Model 2, they are north of 600 participants. This model is retrospective acute and post-acute care. Model 3 is again retrospective, and this is post-acute care only, and they're north of 800 participants as of April 2016. And the last model, which is the prospective acute care model, has 10 participants. Next slide. So bundle payment assumes one payment for an episode of care as defined in different models to pay all providers. We will dive a little bit deeper into what is an episode of care. But this payment pays hospitals, physicians, therapists, all costs associated with readmissions. The hope is that this would lead to improved quality, efficiency in our delivery of care. Episodes are defined by anchor DRGs, and all costs associated with this over a predefined period, which could be 30, 60, or 90 days. Episodes are structured to promote high-quality care for the patient throughout the episode, including appropriate management of pre-existing chronic conditions, coordination among different disciplines, and patient safety. Next slide, please. So again, remember, the payments are retrospective in Model 1, 2, and 3, and Medicare continues to make fee-for-service payment to providers, suppliers providing services through the episode. The total payment for the episode is reconciled against a bundle payment amount predetermined by CMS at the end of the bundle. These models offer potential for sharing the savings and the losses assumed during the episode by the participants. So we basically are betting on delivering the same care at lower cost, cooperation from all stakeholders involved in the delivery of care, and a smooth coordination of care between different stakeholders. Next slide, please. So at this point, I would like for you all to take a straw poll question. We would share the responses as they come through. So the question is your hospital/organization participating or will be participating in BPCI in the next 6 months? You can choose yes, no, or I don't know. And I'm going to give you guys a few seconds to answer this. Looks like we're getting good responses here. So we'll continue and we'll answer the results as it's completed. Let's go to the next slide, please. Okay, go to the next slide. All right. So the next two slides are a little busy, and I apologize for this. We're going to try to clarify some of the nomenclature associated with BPCI. And the way to really simplify it is there's a non-risk-bearing arm and a risk-bearing arm. So if you look to the right of the slide, that's the non-risk-bearing arm. It is associated with the facilitator convener. On the right side of the screen is the risk-bearing arm, which is associated with an awardee or an awardee convener. And we'll explain these terms a little bit more. But remember, the awardee and awardee convener could also come under facilitator convener. Let's go to the next slide and look a little bit more into this. So if you look at your submission types, look at the right side of the screen, non-risk-bearing arm, you have your facilitator convener who does not assume any risk, and they can then partner up with a designated awardee or a designated awardee convener. And we'll explain these two terms, who then can partner up with the episode initiator. So if you look at the right side of the slide is the risk-bearing slide. An awardee is an applicant who bears risk for themselves. This could be a physician group practice or a single acute care hospital. They're responsible for their own bundle payment beneficiaries, regardless of other providers, where these patients receive care during the episode. So they basically are single physician groups or single hospitals, in contrast to an awardee convener, which could be a parent company, could be health systems, other organizations that wish to take risk and partner with other entities. They're responsible for their own bundle payment patients during the episode, all of the bundle payment patients of other episode initiating organizations, regardless of other providers where these patients receive care. A great example could be something like Remedy Partner, which is one of the largest awardee convener, which partners up with MCare as one of its partner, and then they partner up with individual hospitalist groups who are the episode initiators. Remedy Partner and MCare will bear risk with the savings and the losses, and the individual hospitalist group, the physicians who are the episode initiators, do not bear any risk. Another example could be a health system with 5 acute care hospitals. Now, if you again focus your attention right side of the slide, you can have another layer of a facilitator convener. This could be a state hospital association, a venture capital company that does not take risk but engages with an awardee or an awardee convener to participate in this program. All right, next go to the next slide. So what we're going to do now is have a quick rapid fire on some BPCI facts. There are approximately 181 DRGs collapsed into 48 clinical episodes. These include all CCs, MCCs associated with these DRGs. It includes most services covered by Medicare Part A and B for an episode. Most common models are Model 2, which is hospital and post-hospital, Model 3, which is post-hospital only. The episodes could be 30, 60, or 90 days. Remember, during these episodes, CMS continues to pay fee-for-service claims directly to providers, and all the costs are then reconciled retrospectively against the base pricing. Let's go to the next slide, please. Now, the base pricing is based on providers' average Part A and B payments between July 2009 and June 2012. CMS gets 2 to 3% price discount on this. they love keeping some from the top, right? Now there's another gain-sharing waiver. Organizing entities, conveners can share savings with other providers, including physicians in the episode. The convener works with episode initiators, such as hospitals, physician groups, post-acute care facilities, to administer BPCI. This is a very large-scale, 3-plus-year demonstration project in 50 states. Let's go to the next slide, please. All right, so let's take another poll question. If your organization is already participating in BPCI, are you primarily participating in medical bundles, surgical bundles, or both? So I'm viewing it, we're getting good responses. Look like the surgical bundles are 54% right now. Medical bundles are only 12%. We're about 36% for both. All right, so let's go to the next slide now. So this slide depicts Medicare acute and post-acute care payments for 30-day episodes that begin with hospitalization. What's interesting is that even amongst different DRGs, the inpatient spend is only about 50 to 60% of the total cost. And at least 40% cost is associated with post-discharge care. This is from 2014 New England Journal of Medicine. This data is from 2008, and this includes the full amount of all claims incurred within 30 days after discharge. Let's go to the next slide, please. So this slide is from Michael Porter, a Harvard economist, and shows the point of maximum return as it pertains to delivering quality compared to the cost. And the sweet spot is probably somewhere in the middle of that curve. The main two drivers for productivity frontier are operational excellence and optimum coordination. And in general, false trade-offs between cost and quality occur primarily when there is redundant or wasted effort, poor control, or weak coordination. Okay, let's go to the next slide, please. So this pie chart is from Remedy Partner. This shows you an average spend on a bundle for a 90-day episode, which is around $29,991. The anchor admit is responsible for about 33% or close to $10,000, and the rest is spent in post-discharge care. If you look at the post-discharge care piece, the biggest pieces of this pie are the SNFs, the dollars spent on SNF facilities, and the costs associated with readmissions. The two comprise about 39% or $11,700 of the total, which is spent on post-discharge care. So at this point, I would like to turn over to Dr. Alex Strawn, who's going to take us through the rest of the presentation, and thank you so much.
Good afternoon, folks. Next slide, please. So as we move beyond the four walls of the hospital, may the force be with you. What we see here is that hospitals, which were previously required to really be concerned about inpatient costs and inpatient utilization, are now being asked to also figure out how to help manage and control the cost of patients after they leave the building. So we're going to talk briefly about the number of post-acute care settings and variation in spending by diagnosis, as well as the impact of the first site of care after discharge. Next slide, please. So what we see here is the number of post-acute care settings. Astoundingly, there's 15,000 skilled nursing facilities in the United States, which is 2 or 3 times as many as there are acute care hospitals. And 12,000 home health agencies, many of which are owned by hospital administration or health systems or foundations. But in any event, 5.1 million users use those services annually. And as you go across the continuum from least intensive to most intensive, there tends to be some stratification of the risk and disease burden of the patients. But interestingly, for the most part, hospitalists and inpatient doctors really never think about whether the intensiveness of service at these facilities is the important part, but in fact tend to focus more on the needs of the patient. And at times, if there's a lack of family support, make a decision to send the patient to a next site of care that may be a higher level than they need. Next slide, please. Medicare is also seeking to reduce the variation in spending by diagnosis. So if you look at the post-acute care spend variation, the coefficient of variation is 3.2 across 10 conditions. This slide is meant to demonstrate, for example, in the kidney and urinary tract infection bucket, the median of $8,000 for post-acute care spend within 30 days ranges in the 25th percentile of $3,300 to a 75th percentile of $11,000. And the question really is, why is there such a wide variation in the cost after discharge of patients with the same diagnosis? Next slide, please. So what we see here is that regardless of the post-acute services used, there's definitely an increase in cost over the use of home health. And the question is, do all patients who currently go to skilled nursing facilities really need skilled nursing facilities, or can some of those patients be managed with home health or even home with self-care? If you notice, the skilled nursing facility bucket costs about $46,000 on average versus LTAC, which costs almost $80,000. So clearly that first site of care after discharge is going to impact the cost of the bundle. And again, what we realize is that providers probably have not been thinking about this actively in terms of how they manage patients. Next slide, please. So in the best of all possible worlds, the outcome of this initiative would be to get alignment. Since all of these facilities and or providers in the chain are now required to share one payment, the thinking is that physicians, pharmacies, hospitals, SNFs, and home health agencies all need to work together to share the dollar, but also to figure out how to get the best care for the patient at the most appropriate next site of care. Next slide, please. We're going to ask another question here about alignment because we think that this is a really important part of the initiative. If your hospital were to rate on a scale of 1 to 5, always aligned being 5, not at all aligned being number 1, how would you rate the degree of alignment of your physicians with bundled services? We'll pause for just a few seconds. And now we can go to the next slide. So we have to ask ourselves if we're zebras and can't change our stripes, or if we're leopards and can't change our spots as hospital administrators, health system administrators, and physicians have always been able to manage in the fee-for-service world by either charging more or seeing more patients. We're now being asked to manage differently. And there's a variety of reasons for change, which we're going to go into, reasons for our need to change over the next slides. The first one, next slide, please. The first one is that the patients are being discharged from the acute facility earlier and sicker than before. In 1970, as you can see, the light gray graph at the top, the average length of stay for a patient with age 65 and over was between 12 and 14 days in the hospital. And in the last 40 years, that's come down to about 4 to 6 days. And as you can see, although this is true of all patient populations, interestingly, it is most dramatic for the older and sicker patients. Next slide, please. The other important reasons for change include the fact that the timeline for change is very short. Medicare has reached their goal of achieving 30% of Medicare payments being tied to quality. And as Dr. Usman mentioned in his presentation earlier, The alternative payment model target for 2018 is that 50% of all Medicare payments will be in that bucket. So if you really look at this, we only have a couple of years to figure it out as organizations and providers about how to redesign care. Next slide, please. Another important reason for change is that there are huge gaps in care after discharge from the hospital, and one could argue that Medicare beneficiary spending as a feature of the value-based purchasing program is in part driven by the desire to have hospitals become more engaged in what happens after patients leave. In fact, many hospitals and health systems now own medical groups and own physician groups, but getting the patients into their doctor's office is more critical than ever. So if that follow-up is not available, other safety nets need to be developed to receive the patients within the 30-day window. What you'll see at the bottom of the graph in the middle, the bar graph, is that on the left, if you looked at 100% of 30-day readmissions, 50% of them have no PCP follow-up within that month. And that's determined based on claims data where there's no medical bill visit submitted between the time of discharge and the time of rehospitalization. Next slide, please. Another important reason for change is that the bundle payment program is likely to increase in size. And if you look at the near-term shift, approximately 225 DRGs will be in the bundles. But in 2025, long-term shift, it looks closer to 540 different DRGs. So we're going to be seeing things like cancer, end-stage renal disease, and other chronic diseases to start to be placed into these buckets, where the idea would be to manage variation in spending within the episode and manage variation in spending over the course of a variety of different types of episodes. Next slide, please. The other thing to know, again, is that there's significant variation, not just within the total cost of an episode, but within the episode itself. And again, as Dr. Usman pointed out earlier, the post-acute phase, counterintuitively, seems to be one of the biggest drivers of cost. I think most of us who manage or have worked in acute care facilities would have expected that the inpatient hospitalization made up the bulk of the cost, but in fact, quite the opposite is true. So if you see here in cellulitis, the post-acute phase, which is represented in blue, makes up the biggest internal cost. And again, that's skilled nursing facilities, home health, et cetera. Next slide, please. So why change? Obviously, there are financial reasons for change that are significant. MedPAC has shown that post-acute care spending has doubled from 2001 to 2013, from $27 billion to $59 billion. And of that $59 billion, $28 billion is spent on skilled nursing facility care. It's an astounding increase from 2001 when it was only $13.6 million. Next slide, please. So where are the opportunities? 20 to 25% of episode costs with significant variation. Biggest area of waste is clearly skilled nursing facility utilization, and the biggest adverse outcome that can happen in a bundle would be a readmission. Interestingly, in meeting with the folks from Remedy Partners, we've discovered that, in fact, 45% of the readmissions occur after the first SNF visit. So a patient may be discharged from acute care, go to skilled nursing facility, stay there for 28 days, and still be readmitted within the 90-day period. Again, these spending estimates for the different bundles are broken out in a variety of different ways, but at the end of the day, we're looking at 35 to 40% of cost occurs after hospitalization. Next slide, please. So we have to ask ourselves if that light at the end of the tunnel is a good thing, or is it an oncoming train? And given the fact of the recent mandated bundle program, which was the primary reason for choosing this topic, we thought that we would presume that that light at the end of the tunnel is a good thing. Next slide, please. So the average length of stay for hip replacement also reflects that same decline. In patients 75 and over, the length of stay has gone down from 5 days to approximately 4. but our other groups of patients in the age range 65 to 74 have experienced a more dramatic decrease. Now, some of the good news for hospital and health system organizers who've been asked to or mandated to participate in this is that relative to medical DRGs, surgical DRGs tend to be much easier to handle. Typically, there's a cookie-cutter approach to the post-operative period. Ambulation protocols are in place. Skilled nursing facility and rehab relationships are pretty much defined. And typically, the orthopedic surgeons represent usually a reasonable group with which to partner around something like this, particularly if there's something in it for the providers. But the point is that it's the same cost pressure and the same time pressure going on, and it seems to be, again, affecting mostly the elderly. Next slide, please. So there was a recent Becker's article that indicated that we should have all seen this coming, and I would think that's probably true, given the fact that CMS's track record has really been to do demonstration projects, validate that this change is going to save them money, and then eventually mandate this. So the bundles are now mandatory for comprehensive joint replacement. There are 60 health systems and/or acute care hospitals that were chosen based on variation in cost, and this is CMS's attempt to lead the charge in shifting risk to providers and making payments based on quality and outcomes as opposed to volume. Next slide, please. Just in the background here, the DRG system did shift some risk to the hospitals. Obviously, the 13-day length of stays were probably not appropriate. So at some point, the decision was made to pay a fixed amount for each diagnosis. And in that system, as hospitals became more savvy, they were able to shorten the length of stay and to win a little bit in the DRG system. In the bundle payment, now they're including the post-acute care period and things that happen after the patient leaves the hospital. Next slide, please. So here are the prior bundles. The 2009 acute care episode, which was limited to cardiovascular and orthopedic episodes, and the 2013 BPCI Voluntary National Program, which is now mandatory under CJR. Next slide, please. Again, in these, you can choose from 48 episodes of care and regular bundles, and choose between a 30 and a 90-day post-acute period. Depending on the amount of risk that you're willing to take, longitudinally, the rewards and gains are a little bit better at the 90-day window. You're permitted to take economic risk on the episode of care, but again, we expect that bundles will be mandated eventually for medical diagnoses as well. Next slide, please. So if you were to take a look at CJR, it's literally a direct offshoot of Medicare's prior programs. It's going to be based on Model 2, limited to total joint replacements, mandatory, and the hospitals will be put at risk by CMS. So we're going to talk a little bit later in the conversation about what would be necessary to be successful here, but at the end of the day, hospitals are going to have to be involved in and responsible for coordination of care. Next slide, please. So our next poll question is, if you are participating in surgical bundles, are they orthopedic bundles or other surgical bundles? Next slide, please. So interestingly, one of the things that we've noted is that the patients really are not informed about this program, and there's a lot of controversy around what is paid for after patients leave the hospital. We do know that there's a skilled nursing benefit that's 28 days. This is one of the big levers for CMS because the 28-day benefit matches exactly the average length of stay in most community-based skilled nursing facilities. Whereas for Medicare Advantage plans, since the benefit is only 14 days, the length of stay seems to match. So again, Medicare's thinking here is that they can trim half the cost off of the post-acute setting by reducing the length of stay. But interestingly, the patients are either not informed or very, very aware of their benefit. And in our experience, when we talk with our patients who are in skilled facilities about leaving earlier, they're very aware of the fact that Medicare benefit covers for 28 days. So there's going to be a lot of coaching and patient engagement required. The other thing is that if patients are going to need additional services in the home, they have to sign consents to receive those services. So as you think about the next site of care, home with home health, skilled facilities, LTACs, rehabs, one of the things to think about is that interventions in the home would probably help, but patients have to be engaged for that to happen. Next slide, please. Here's a few slides that show hospitals in our catchment area where we're doing bundles, and these just reflect patients who receive the outreach while in the hospital. Typically for us, this involves a risk assessment, which includes a fall assessment, a depression assessment, a readmission risk assessment, and then there's some evaluation of activities of daily living. We carefully select the next site of care, but even though the patients become engaged and may sign up while they're in the hospital, they may ultimately end up canceling. So here at Hospital A, next slide please, Hospital B, and at Hospital C, next slide please, you can see that we have patient engagement issues. And I think that this is going to be very important while they're within the four walls of the hospital to make sure that they understand that this is a concierge program offered by Medicare. The other thing that we think is probably going to be necessary is some modification to the payment methodology for patients who receive home care. Next slide, please. So again, where this is all going, and the bottom of the slide here in gold, it shows a healthcare transformation task force. 75% of Medicare's business will go to contracts with incentives for quality and lower costs by 2020. This is the stated goal, 50% of all payments by 2018. And unfortunately for our hospital partners, the brunt of the cost is being borne through the value-based purchasing program, which, again, as I mentioned, now includes a Medicare spending per beneficiary as part of the cost structure. Next slide, please. So if we were to glimpse into the future and say, what can we expect, we have no reason to believe that CMS will stop 50%. Again, the dark side of the force is at work here, but hopefully they will understand that there will need to be some modifications for what will be paid for in the community. For our hospital partners and health systems, it's critical to understand your costs, collect and analyze your claims data, redesign and coordinate care, and design incentives with providers for alignment. Next slide, please. So what are the keys to our success? Number one, provider communication training. How well doctors engage in conversations about palliative care, about next site of care, about reduction in length of stay on the inpatient side, outpatient side, really is going to be important. And effective patient engagement in post-acute care and recovery is key. The other thing is that proactively we should be mapping our patients' progress across the episode time frame and start to identify deviations. One of the things that we see a lot is if the post-acute providers that are chosen are not good partners, that the patients end up back in the emergency room. Sometimes that's medically appropriate, sometimes it's not, but at the end of the day, those patients end up being readmitted very often. And obviously now that hospitals have penalties against them for readmissions, we need to start to identify the network of providers that would help us succeed. Again, integration of unaffiliated post-acute providers, I already covered that, and continual communication with patients and family and caregivers. Next slide, please. The other parts of success we think, especially in the joint program, is going to be early ambulation. Many hospitals already have protocols for something like this for patients who receive joint replacement. Collaborative ambulation program typically should involve nursing and physical therapy. There's a huge movement now to having these procedures done in the outpatient world, and some patients never see the inside of an OR for these procedures. So at the end of the day, there will be competition for this business, and I think that acute care hospitals would need to be able to prove and continue to demonstrate that the value resides in performing these procedures within the four walls, but that we're able to work and coordinate care on the outpatient side. Medication reconciliation is a really big part of care transitions, but again, we find ourselves in a situation where we're struggling to make sure that that information is transmitted to the next site of care, and that if the patient is not doing well at the next site of care, that there are other interventions available. Next slide, please. So the new business imperative is basically care process redesign. And in order to achieve this, we feel that clinical and non-clinical care processes will need to evolve. We decided as an organization to take a process-oriented project management approach and engage all stakeholders, and have had varying degrees of success in doing that, but we do have some tactics that we'd like to share with you. Next slide, please. One of the tactics that we think is important is that the hospitalist must become excellent at documentation. And obviously, Dr. Usman mentioned that there is a DRG here, but the DRG obviously has either major comorbidities and complications, or no comorbidities and complications. So if you have patients who have comorbidities or major comorbidities, those should be documented carefully because that does impact the expected bundle pricing. The other thing is to think more carefully about discharge level of care at discharge destination. Remedy has designed a tool called Care at the Right Location, the CARL tool, which can be embedded into billing software, charge capture programs, and also integrated with their other tool, which is called Episode Connect. And there's a way to kind of track and follow the patient and actively manage. Care coordination is critical. In our model, we added transitional care RNs and associate practitioners in the field to do home visits. Readmission reduction clearly is going to require narrowing the network of skilled facilities so that we don't have sendbacks that are inappropriate, and also figuring out if we have SNFs partners or organizations that can provide care in the skilled facilities. And last but not least, certainly one should be considering palliative care when appropriate. Next slide, please. So at Envision, we feel that patient engagement is at the center. We must engage the patient in self-management post-discharge. That's going to require effective health coaching and monitoring and managing health-related social factors. Patients who don't have a refrigerator can't store their insulin. Patients who are depressed may not make their follow-up appointments. So non-medical important social factors have to be identified and managed as well. And we really feel that stakeholders working together to control costs and maximize patient outcomes, and again, minimizing avoidable readmissions is a big part of success. So with regards to a tactical approach, next slide please. One of the things that we've done is we've developed a card that goes on the back of the ID badge for the hospitalist. And this just lists the different DRGs. As you can see for sepsis, for example, there's 870, 871, and 872. So this is with an MCC, with a CC, or without a CC. And again, each one of those is going to have a different bundle price. Obviously, our focus, as you can see from this card, is medical diagnoses. Next slide, please. We also have developed a wristband, which has been a big success in helping us identify patients and kind of getting the patients engaged in understanding the program. Obviously, there's a lot of time spent with the patients and their families, indicating to them what are the parameters of bundle payments, why is this important, how did this happen. And interestingly, a lot of our patients have said it's about time. They feel really gratified that Medicare is starting to think about a patient-centered model of care. Next slide, please. So I want to thank everyone and answer any questions that you might have at this time.
All right, yes, thank you, Dr. Strawn and Dr. Usman, for that informative and enjoyable presentation. We will now begin the Q&A portion of today's program. As a reminder to our audience members, you can submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenters will attempt to answer as many questions as they can during the time we have left for the webinar. The first question for our presenters is, what are the advantages of outsourcing the management of the portion of care outside the hospital walls for bundled payments? Dr. Strawn, maybe you could start?
Yeah, so I think one of the advantages is that the infrastructure is already built. I think there's a relatively steep investment curve involved in building an infrastructure that includes transitional care nurses, outpatient APPs, SNFs in the field, and there are a lot of different touch points with the patient that it would be difficult, I think, for hospitals to set up. I mean, literally, unless you own your own providers, having docs at the skilled facility level, having docs who are inpatient specialists, working with emergency departments, et cetera, there's a lot of care coordination involved, but it's primarily driven by providers. A lot of the decision points in this process will be driven by doctors deciding to admit, readmit, not admit, or to figure out how to keep the patient from overutilizing. So since we've built a lot of that infrastructure here in Envision, I think that there's an opportunity for clients to partner with organizations like ours that have done that. Asim, did you want to make a comment or?
No, I think that's pretty accurate.
Okay. Any other questions?
Oh, yes, I'm sorry. Sorry, the next question from the audience is, what do you think will be the next bundled demonstration?
Well, I'll take a stab at that one. I think that there's likely to be medical diagnoses probably related to chronic disease. And again, there's a lot of coordination involved here. Hospitals and health systems already have initiatives around COPD, CHF, acute MI, and pneumonia because those are where the readmission penalties lie. So I would expect that as we segue into medical diagnoses, those that are most frequently readmitted would probably be first because there's clearly alignment between hospitals and providers to prevent that. Secondly, though, would be chronic diseases that have high cost. So one example, I think, is going to be end-stage renal disease. It would seem to me that there's probably a lot more available in the outpatient, clearly more available in skilled facilities now for those patients to receive care other than being inside the hospital. So I think that there's going to be a shift from surgical, procedural diagnoses over to medical diagnoses.
Great. Dr. Usman, anything to add?
No, nothing else to add.
All right, thank you. The next question is, can a hospital make money with bundled payments? And if so, what does it take to do so?
Okay, so the biggest single thing to note here is that this still is built on a fee-for-service architecture, right? So everybody who presents a bill to Medicare during a bundle will still be paid the same. And the reconciliation, as we mentioned, is post hoc. So if the expectation is that an episode base price is $20,000, CMS's 2% discount to $400. If you have a convener involved, they typically have a 2% as well, so that it amounts to an $800. So if you can manage that case for less than $19,200, then you get to keep the upside. The problem is that you also have to pay the downside. So if the cost of the episode is $800 more, if you're doing 1,500 hips, it can rapidly get to be expensive. So I would think that, yes, there's an opportunity to make money, but you have to scale the infrastructure to support care redesign, and you have to have this heavily protocolized. You have to have physicians aligned with you, and the way to do that is typically to have them participate in the rewards. We haven't met many physician groups that are willing to participate in the downside, but they all seem to be willing to participate in the upside.
And I agree with that. And I think to that point, the larger the project is, and you can offset some of the high-cost areas with some of the benefit of saving costs, I think there's more of an opportunity to partner up with physician groups and hospitals.
Well, at the end of the day, this is going to become business as usual. So, you know, it has to happen one way or the other. Any other questions?
Thank you. Yeah, thank you both. The next question is, what can we do to get patients more engaged in their care for purposes of bundled payments?
Okay, so one of the things that we've found really, really successful is to dedicate staff, dedicated transitional care RNs in our practices will see basically all Medicare patients. And part of that is we're hedging our bets a little bit. We know who will be in the bundle only 10 to 30 days after discharge, right? So you've got patients who are Medicare patients. What we do is we have our transitional care RNs around on those patients. And when they do that, not only do they perform the risk assessment tool, but they create patient engagement. The patient becomes aware of their diagnosis. They become aware of the treatment. They become more aware of the treatment plan. But more importantly, they become aware that someone actually cares about them. And I think that hospitals obviously care about the patient, but sometimes struggle with having a resource that's dedicated to sit there and spend an hour answering questions with these patients. So typically, from a productivity standpoint, it's tough. Our TCCRNs may put in a 12-hour shift and only be able to see 12 to 15 patients in that time. But it's been a huge boon because when they receive the follow-up phone call, from those folks, it's very, very gratifying. We've had a couple of instances where, literally things like meds not being filled upon discharge, et cetera, where we were able to catch that before the patient represented. So I think that it's time to decide to dedicate staff to this. Obviously, given the financial constraints that our hospital clients face, that may be an issue. But in particular, if you're in a mandatory bundle, we think it's kind of a necessity.
And I think this is a real point with the patients. They sometimes don't understand what this program is. And we are engaging our hospitalists in setting up this program for the patients. So some of our programs, we have our hospitalists rounding with a transitional care nurse or vice versa to explain this program and to set it up for the transitional care nurse.
Great. Okay. Thank you both. The next question is, what do you recommend as an incentive structure for physicians who participate in episodes impacted by bundled payments?
Yeah, so I'll take the first part of this. I think if it's legal and kosher to incentivize readmission reduction, and again, incentivizing docs is hard because they typically only want to be incentivized on things they feel they can control. But, in the case of our SNPs, for example, that's one of the corridors that we're entertaining. In the models where the docs are employed by a hospital or health system, it should be relatively easy to do this. So incentivizing readmission reduction kind of kills two birds with one stone. Typically, it helps the hospital avoid a penalty, and if they're in a bundle, it helps them have focused diagnoses that they can choose from. And that forces care coordination among providers. That kind of forces them to take a look at, hey, this patient's in the ED, does he need to come back in? Now, obviously, outside of the 30-day window, some of our hospital clients would still prefer to readmit that patient because we're all being asked to live on the tip of the spear here where we're going over to value-based payments, but we still live in a fee-for-service world. So there's a delicate balance there, but certainly I've seen length of stay and readmissions in incentive programs for employed doctors. Clearly, readmission would be a big lever here. Sim, did you have anything to add?
And I think the other thing to pay attention to, we are putting this metric more and more as a quality metric for our hospitalist group. But the other ways to look at it would be to look at, are the medicine reconciliation done in a timely manner 100% of the time? Does that affect readmission? Are the hospitalists making appointments or in partnership with case management, appointments with primary care physician at the time of discharge? We're really pushing timely discharge summaries. Our goal is for the patients to head out of the hospital with the discharge summary in hand. That's our big initiative this year, which would really help close the loop with the primary care physicians. I think those are some of the strategies which could be looked at. One other lever is identifying the right person to communicate with. So very often we find in our elderly population, we might not be talking to the right caregiver even in some instances, the patient could be totally aware of what's going on, but that one daughter who's involved in the care, if she is not kept informed, that really breaks down care once the patient leaves. So those are some of the strategies we're using to really address our readmissions.
And one of the other ones, I think that earlier intervention in terms of expectations with the patient, we've been doing that in the hospice world for a while to kind of frame length of stay expectations, for example. But now we're looking at patient care conference within 24 hours of admission, which involves exactly the stakeholders that Sim mentioned. So we would want to have the daughter, the caregiver, the husband, and the patient sit down with our hospice and our TCC and talk. And some of our clients have been willing to create incentive corridors around that. There's a model out there called the Plane Tree model.
So I think another big area which will get more and more relevant down the road would be somehow addressing palliative care early in these elderly population. And I think you'll see a lot of push being done on that front in the next 12 to 24 months.
Okay, great. Thank you both. I think we have time for one more quick question. That question is, I noticed the focus on primary care physician follow-up related to readmissions. What is the specialist follow-up for the remaining 50%? Also, is the primary care physician visit statistically significant for non-readmitted patients versus readmitted patients?
Yeah, and I think the answer is clearly the primary care follow-up is probably the key, although I don't have data because this was from a New England Journal article, so I don't have data regarding specialist follow-up. It literally just speaks to the fact that no one sees the patient 50% of the time because there's no bill drop with Medicare. Now, I guess one could argue that for doctors that operate under a global fee, for example, there may not be an additional bill generated. So maybe in the surgical specialties or procedural specialties, there's an additional bill not generated, so that's not seen. But I would argue that if there's no bill drop, that it probably means the specialists haven't seen the patient either.
Okay, great. That's all the time we have. I want to again thank Dr. Strawn and Dr. Usman for your excellent presentation and for all of our audience members for participating today. We look forward to having you join us for future webinars. This concludes today's program. Have a wonderful afternoon.
Thank you.
Thank you.